progressive loss of insulin secretion and ultimately hyperglycemia. I do that because it's a good context to then discuss the medications that we use to manage diabetes. I'm sure this is very similar in pulmonary diseases like asthma. Understanding the pathogenesis of disease makes it much easier to understand the medications that we use to treat hyperglycemia. We'll talk about diabetes treatment targets, specifically hemoglobin A1C. And then we will touch upon the older type 2 diabetes guidelines only in an effort to compare them to the newer guidelines, which have been driven by the clinical trial data that I alluded to before. And then we'll finish up with some take-home messages for pulmonologists. So pathogenesis of diabetes. Type 1 diabetes is a very easy disease to understand pathophysiologically. The immune mechanisms are very complex, but at an organ level, it is really the loss of beta cells themselves, and therefore beta cell secretion that drives the hyperglycemia. When you contrast that to type 2 diabetes, it's much more complicated. While there is a beta cell defect in type 2 diabetes, the disease really starts in peripheral tissues, specifically the skeletal muscle and the adipocytes, that express something called insulin resistance, meaning that they need more insulin to transact glucose metabolism. And that's denoted here by a decrease in peripheral glucose uptake. Now, most of your friends or family members that have put on a few pounds over the years, who are overweight or obese, have some degree of insulin resistance. And we don't measure insulin levels. Insulin levels tend to be high in these patients because the pancreas is striving to keep blood glucose levels normal. And in order to do that, it has to hypersecrete insulin. But in your basic and comprehensive metabolic panels, when's the last time you saw an insulin level? We measure glucose. And because glucose levels are maintained normal at the expense of hyperinsulinemia, we think that everything is fine. But actually underlying this is significant hyperinsulinemia. And over time, the increase in insulin secretion wanes. We don't understand what predicts that or how that develops, but it's a exhaustion of pancreatic beta cells. And now we have a conundrum. We have the peripheral tissues that need more insulin, and the pancreas is not able to any longer provide that amount of insulin, and that is obviously a recipe for hyperglycemia. So those are the two major organs, these peripheral glucose uptaking tissues, muscle and fat, and the endocrine pancreas. The liver is also involved. It's a glucose producing organ. During meals, it's supposed to suppress its glucose production and becomes a organ of net glucose uptake. That is not happening normally in patients with type 2 diabetes. The liver continues to make glucose because it also is insulin resistant, and insulin is supposed to suppress hepatic glucose production. It doesn't do that in the postprandial setting. There are incretin hormones that are deranged in patients with diabetes and prediabetes. These are the peptides known as GLP-1 and more recently GIP that we'll talk about because there are some medications that are based on those incretin hormones. This is a kind of a neuroendocrine dialogue between the GI tract and the endocrine pancreas that is supposed to augment insulin secretion when you need it and also suppress glucagon when you don't need it, because it's the opposite of insulin in terms of turning on hepatic glucose production. As mentioned, the incretin signals, whether their levels themselves or their activity, is decreased in patients with diabetes, accentuating the pancreatic insulin secretion defect and augmenting postprandial hyperglucagonemia. So it really becomes a bit of a metabolic mess, this type 2 diabetes. The kidney is also involved in the process. It's a glucose excretory organ. It's supposed to be something of a safety valve. It releases glucose once the plasma glucose concentrations hit 180. And that threshold is actually increased abnormally in type 2 diabetes. So the kidney can't even get rid of enough glucose in the diabetic state. These all conspire together to promote hyperglycemia. So it's confusing from a physiological standpoint. It's very attractive from a pharmaceutical company standpoint because you can actually develop a compound that directs one or more of these pathophysiological abnormalities and improve glucose metabolism. This explains why there's so many individual compounds to treat type 2 diabetes these days, whereas in type 1 diabetes, there's essentially one treatment, which is obviously insulin. So this is what I just said, but put in the framework of the kind of the lifespan of a idealized patient with type 2 diabetes. In the obese state, an NGT here refers to normal glucose tolerance. So these are patients without any evidence of hyperglycemia. They become insulin resistant related to their weight as well as genetic factors, et cetera. And you can see insulin secretion keeps in step with that insulin resistance. And as the glucose metabolism becomes abnormal, we call this phase pre-diabetes, either impaired glucose tolerance or impaired fasting glucose. They mean a bit different things, but they point to mild hyperglycemia, not to the point of diabetes. And here's where you begin to see this disconnect between the amount of insulin that can be secreted and the amount of insulin that is required. And that translates to initially an increase in the postprandial glucose and ultimately an increase in fasting glucose. And once the glucose gets high enough, and we define this as a plasma glucose concentration fasting of 126 milligrams per deciliter or higher, or the hemoglobin A1C reaches 6.5% or higher, we call that type 2 diabetes. But it's all on a spectrum, isn't it? And we have patients that are hovering around this diagnostic threshold that 1 month may be sub-diabetic, if you can use that term, and another week or month they may actually meet the criteria for type 2 diabetes. The insulin secretion continues to wane as we get older. We lose beta cell mass. And as diabetes progresses and is untreated, you can develop hyperglycemia that is uncontrolled. Naturally, you can deal with the mild abnormalities with oral agents or non-insulin injectables, and we'll talk about these. But ultimately, when the beta cell function is pretty anemic, never to the point of type 1 diabetes, which is a total absence of insulin, but you can get some long-term type 2 diabetic patients that have very little insulin secretion, C-peptide secretion. And in those individuals, those are the ones that require insulin therapy to manage their disease. Importantly, they're not insulin dependent. We keep hearing that from trainees. We don't use that terminology anymore. It's type 1 and type 2 diabetes. Insulin dependent is a very confusing term because certainly a type 1 is insulin dependent. They depend on insulin for survival. In type 2 diabetes patients, they don't depend on insulin for survival. They require insulin for glucose control. So it gets very confusing to use that terminology, NIDDM, IDDM. So we prefer type 1 and type 2 diabetes. I'm not sure if that's actually clearer, but that's what the ADA recommends. Okay, so that is a background of what type 2 diabetes is and how it progresses, and how do we treat it? Well, as mentioned, there are many different formulations, compounds, many in different combinations of 2 and 3 drugs in one tablet that lower glucose levels, obviously through different mechanisms of action. There are 12, and you're going to have to trust me on this. 5 we never use. So it makes a nice slide, but I'm going to take away 5 and talk about the 7 major drug categories for diabetes. Conveniently, they're grouped into what I call 2, 2, 2, and 1. What do I mean by that? Well, there are 2 drugs that augment insulin supply. And this would be exogenous insulin injection, obviously, and also sulfonylureas that stimulate your own pancreas to make insulin. And there are 2 drugs, metformin and thiazolidinediones, TZDs, one working mainly in liver, the TZDs working mainly in muscle, that are considered insulin sensitizers. So they make the body more sensitive to the actions of insulin. There are 2 drugs that address the incretin abnormalities in this disease, the GLP-1 agonists, and more recently, a GLP-1 GIP coagonist, and the DPP-4 inhibitors. The DPP-4 inhibitors basically inhibit the enzyme that breaks down one's own incretin hormones and therefore allows for higher incretin levels endogenously. And the one that stands alone are the SGLT2 inhibitors that reduce the glucose threshold for excretion, allowing more glucose to enter the urine. And if it's in the urine, it's not in the plasma, and that lowers the hemoglobin A1C. So 2, 2, 2, and 1, and those are the major drug categories that we use to treat type 2 diabetes. Just to make a few points about each, you all know metformin is a biguanide. It reduces hepatic glucose production, can be considered an insulin sensitizing agent. The attractiveness of metformin when it first came out in 1995 is that it was the first drug for diabetes that didn't lead to hypoglycemia. And it could also be used in combination with sulfonylurea drugs. So we could actually use two drugs in combination and not need to resort to insulin to control diabetes. So that was big news in 1995. There also may be some reduction in cardiovascular events, but these are based on older and smaller trials. And I don't think we'll ever know if metformin is a cardiovascular friendly drug. It's friendly in that it doesn't aggravate cardiovascular complications, as has been proposed with some medications, but it's not, as we'll hear about with the SGLT2s and the GLP-1s, not something that definitively reduces cardiovascular events in these high-risk patients. GI side effects, so those of you that have prescribed it, you know that most patients will complain of diarrhea, particularly if you give too high a dose initially. And then lactic acidosis can occur typically in people that have advanced CKD. So if you don't use it under a GFR of 30, you probably won't ever see a case of metformin-associated lactic acidosis. Obviously, metformin is used so commonly that eventually you're going to get somebody who gets sick and gets lactic acidosis, but in that circumstance, it's probably not related to the metformin. It's probably related to, the anterior wall MI, the sepsis, et cetera, that has led to the lactic acidosis. Although sometimes it's confusing whether metformin was contributing, particularly if they have AKI at the same time. So SUs and the TZDs are the other oral medications that we consider the older drugs. These stimulate insulin secretion by closing potassium channels. They obviously lead to hypoglycemia. They're not glucose dependent in their effectiveness as some other agents are, and they have low durability. The analogy is if you're whipping a tired horse, which is what the SUs do to the failing pancreas, they kind of peter out in terms of their effectiveness after a few years. But they have been demonstrated to reduce microvascular risk, retinopathy, nephropathy, and neuropathy. So, when you lower glucose through any means, you're supposed to reduce microvascular risk. Not the same for macrovascular risk, but hold on that point. The TZDs are the glitazones. Pioglitazone is the only one that's still on the market. Also no hypoglycemia, better durability. So this is, the analogy is, that I like is it's an afterload reducer for the pancreas because it makes the body more sensitive to insulin. The body has to make less insulin, and it's more durable than certainly the sulfonylureas. And there's also evidence, some from Yale, that the TZDs, specifically pioglitazone, reduces cardiovascular events. Lots of baggage with this drug class. It was very popular in the early 2000s and became less popular as we became aware of some of the warts of the glitazones, including weight gain, edema, heart failure in predisposed individuals, mainly from sodium retention, not a detrimental effect on cardiac function. And it also increases the risk of bone fractures in women. And the last two oral medications that I'll review are the DPP-4 inhibitors. These have become extremely popular, so-called gliptins. The most commonly prescribed ones are sitagliptin and linagliptin. Also no hypoglycemia, extremely well tolerated, virtually no side effects, but relatively modest in terms of its A1C lowering effects. And the SGLT2 inhibitors, we'll spend some time talking about this class. These are the flozins. These are the ones that reduce the renal threshold for glucose excretion, increasing glucosuria, and in addition to no hypoglycemia, significant benefits. And this is where the guidelines have changed remarkably just in the past 5 or 6 years, encouraging the use of these medications in those who might benefit. CVD patients, certainly heart failure, and definitely CKD patients as well. So we'll talk about those indications later on. As you might imagine, when you put sugar in your urine, you can get infections. Interestingly, not the UTIs that we were initially concerned about, but genital mycotic infections, particularly in women. So you have, when you're prescribing this medication, you have to go over that. It can occur in men as well. They can get candidal balanitis, but it's easily treated with conventional therapeutics. And then, interestingly, euglycemic decay has been reported with the SGLT2s. The reason for this is not entirely clear. It may be related to an increase in lipolysis, an increase in glucagon, a decrease in ketone clearance. It's still not well worked out, but it first emerged in the clinical off-label use of this class in type 1 diabetes. Don't use it in type 1s because about 10% of patients will go into DKA. But it can occur in type 2 diabetes. Typically, those patients that are very far along in their insulin secretory deficiency, in other words, older patients that really have had diabetes for a long period of time, have very little insulin secretion, are type 1-ish. When you give them an SGLT2 inhibitor, there's a greater risk of DKA. And because they're still losing glucose through the urine, the glucose levels in the setting of this DKA is much lower than you typically see. I mean, the diagnostic threshold is 250. It's actually being lowered to 200 based on the new ADA criteria. But you'll see patients with DKA with a blood sugar of 140, 150. And it's really confusing for the poor emergency room physicians because they see somebody coming in who has a metabolic acidosis, is breathing quickly, and they say, you have diabetes? Yes. Oh, you must have DKA. Let's check a finger stick. It's a lot quicker to get the finger stick than to wait for the laboratory to return the BMP. And the glucose ends up being like 150. So the first impression is, well, this can't be DKA. Aha, it is DKA because they're on an SGLT2 inhibitor. It's very, very interesting. I'm sure you've seen cases in the ICU over the past few years. Then transitioning to the injectables, there are two categories, the GLP-1 receptor agonists. These are the now famous drug class. Everybody and their uncle seems to be on these medications, and not necessarily for diabetes, but for weight loss. These are the tides, they're all in Tide. One is both injectable and oral semaglutide, and significant weight loss, particularly with the long-acting weekly formulations, and particularly at higher doses. Now here we're talking about, now in the prior era of weight loss medications, obesity medications, people got all kinds of excited if you lost 5% of body weight. With the GLP-1s, 10% body weight loss is routine, 15% body weight loss is common, and the more potent medications are now approaching a 20 to 25% weight loss, which is dramatic. If you think about a 200-pound individual, to lose 40 or 50 pounds is life-changing. We're starting to flirt with the lower end of what is achievable with bariatric surgery. I'm not sure we'll ever get to the types of weight loss you can see with bariatric procedures, but we're getting close to the lower end of that range, particularly for sleeve surgery and certainly for banding. No hypoglycemia, and here you have a clear reduction in cardiovascular events, which is very exciting because not only are you leading to a cosmetic loss of body weight, you're actually improving something to do with the atherosclerotic process. GI side effects, it slows the bowels down. Patients, if you're giving them too much too quickly, they can get severe nausea and sometimes vomiting. It can induce almost a gastroparesis type state. It should be reversible. There are some interesting recommendations that I'll touch upon from the American Society of Anesthesiologists about what to do with these medications in the pre-op setting, which is interesting. And most are injectables, as mentioned, although one is mentioned is oral. And then insulin, we know how it works. It's a drug that's been demonstrated to reduce microvascular risk, but it also has lots of baggage. Most patients don't want to take insulin if they don't have to. There is hypoglycemia and weight gain, and most are injectables, but not all. And that is actually pertinent to your specialty because the non-injectable insulin is now an inhaled insulin, which you should at least know about, although nobody prescribes it. The GLP-1 GIP receptor agonist, so we're getting a little bit complicated in the incretin-based field because there are multiple receptors that can affect appetite. GLP-1, glucagon-like peptide 1, that's the one that most of the compounds have been directed against, or toward, these are agonists, not antagonists. Then there's GIP, which is glucose-dependent insulinotropic peptide. It used to be called gastric inhibitory peptide, but now it's another GIP. That also affects appetite and insulin secretion, and a co-agonist, a single compound called tirzepatide, activates both receptors. There's a triple receptor. There's one activating GLP-1, GIP, and glucagon, which reported a 25% weight loss in a small clinical trial. So the field is getting obviously very, very interesting. This is the inhaled insulin. It is, I'm not supposed to use trade names, but it's important for this because nobody knows it other than by its trade name of Afrezza, and it's actually inhaled in these doses, but there are some warnings in terms of not using it in smokers, not using it in people with COPD or asthma, having to make sure the patient has a normal FEV1 before you treat, and to follow it every 6 months initially. It's a little bit cumbersome, which speaks to why no one prescribes this medication, but it has been out actually since 2014. In terms of treatment targets, these are the latest guidelines from the American Diabetes Association. It hasn't changed that much in years. We target a hemoglobin A1C, which is a 2 to 3 month marker, as you recall, of the average glucose during the day and evening. It correlates with a mean glucose of about 154 milligrams per deciliter, and that should be less than 7%. Many of our patients, and I'm sure you've seen this in the hospital, are coming in with glucose sensors. These are, I call them Holter monitors for glucose. They are 24-hour devices that measure interstitial glucose and really open up a whole new world for these patients, particularly those on insulin regimens, especially those who have type 1 diabetes on insulin pumps. So they can actually navigate their day. They can see exactly what their blood glucose is doing. They can see if it's going up or going down. And the metric that we use when we get these complicated reports, I'll show you an example, is the so-called time in range. And that is the minutes of the day that you're between 70 and 180 milligrams per deciliter. And the target there is to get that marker over 70% of the day. This is the reports that we generate when patients come into us with these sensors. You can see this person might have this is a GMI, which is a glucose management indicator, which approximates or predicts what the A1C should be. So this person's A1C is 7.5%, which is not too bad, but you can see that there's lots of room for improvement. Hypoglycemia overnight, which is dangerous. Postprandial hyperglycemia that can be easily addressed. So it gives you a lot more rich information than just looking at the hemoglobin A1C. The two that are marketed and you'll see patients on are the Libre device and the Dexcom. And these devices are getting to the size of about a nickel. They're actually quite accurate, and they're approved for type 1s and type 2s on insulin therapy. I think you'll see a lot of patients using these who are on metformin. It's great. It's wonderful to have more data, but it's not really necessary for the more mild diabetic patients. So managing diabetes is not just about glucose because, as you know, these patients are at high cardiovascular risk. So we spend just as much time worrying about their blood pressure and their lipid management in addition to their glucose control. So quickly, the blood pressure target now is less than 130/80. If you have CVD or if you have albuminuria, we start with a RAS blocker, but we can use in other patients either a RAS blocker or a calcium blocker or even a thiazide. And for lipids now, if there's no cardiovascular disease, the target is less than 70s. And these are recommendations that are harmonized between ADA and the American College of Cardiology, the ACC as well. If there is prevalent CVD, the LDL target is now less than 55. And high-dose statins are basically what we use in the vast majority of our patients, which would be Atorva at least 40 or Rasuva at least 20. Okay, so let's look at the older type 2 diabetes treatment guidelines. And just before I show you those, I want to give you a glimpse at 25 years of type 2 diabetes clinical trials before the latest cardiovascular outcome trials, because this is what the older guidelines were based on. The bottom line is that when you control glucose in both type 1 and type 2 diabetes, it's now known and recognized that you reduce microvascular complications. So those would be nephropathy, retinopathy, and neuropathy. Those three diabetes complications, which occurs both in type 1 and type 2 diabetes, are attenuated when the hemoglobin A1C is brought toward 7% or slightly lower. And that's where the guideline recommendation comes to target an A1C of 7%. Confusingly, when you do that, you get the A1C down, there is no data to suggest that you improve the macrovascular complication. This has been one of the most frustrating aspects of diabetes clinical trials over the past several decades, is that you have a disease that is marked by hyperglycemia. That's the major metabolic abnormality. You have a disease that doubles the cardiovascular risk. So it's intuitive that if you improve the glucose, you should knock down the risk of cardiovascular disease, stroke, MI, CV death. No data to show that at all. And the reasons for that are beyond the time we have to discuss today, but it may be the wrong drugs, it may be the wrong targets, it may be too little too late. It's controversial as to why, but micro benefits, but no macro benefits. In fact, there was one large trial in the early 2000s called Accord, where the most intensively managed type 2 diabetes patients actually had more cardiovascular deaths. And that really rocked our world because we think we were doing benefit to patients by controlling their hemoglobin A1C, but that was not the case. And now if you look at individual drugs from the old days, so insulin, sulfonylureas, metformin, and the TZDs, insulin and SUs are neutral. At one point, they were thought to increase the risk of CVD, but they don't. They're neutral. They'll lower glucose, and you'll get all the microvascular benefits of lowering glucose, but you won't impact cardiovascular events. Metformin, smaller, older trials suggested a slight benefit in cardiovascular outcomes, but not a very robust database. And for the TZDs, pioglitazone has been shown to reduce MIs and strokes, specifically stroke, but it's counterbalanced by the side effects, including heart failure. So you can reduce MACE events, but increase heart failure events. You know, how you thread that needle in which patients has been somewhat controversial. So the bottom line is that glucose control itself, using any drug or using these older drugs, has not been definitively shown to clearly improve cardiovascular outcomes. And that was reflected in the guidelines. So these were the guidelines that we wrote in 2012 and updated in 2015. And essentially they said that you start with metformin in addition to lifestyle change, to lose weight and get more physically active. And after metformin, you came in with one of these 6 drugs, whether it's a SU, a TZD, a DPP-4 inhibitor, SGLT2 inhibitor, GLP-1 agonist, or basal insulin. And you basically layered on these medications targeting a hemoglobin A1C of 7%, or whatever you thought was the ideal hemoglobin A1C for that patient. But there was really nothing about cardiovascular benefits of one drug versus another because we had no data. We would start with dual therapy if the hemoglobin A1C was high. If the A1C was super high, we might start with insulin therapy. But it was basically a glucose-centric set of guidelines, not acknowledging any specific benefit on the cardiovascular system. So things began to change in 2015. And this is when the FDA mandated cardiovascular outcome trials began to be released. So this is the 7 drug categories that I mentioned before. And neutrality for SUs and for insulin is quite clear. They do not, even though they reduce glucose, they don't reduce cardiovascular events. And as mentioned, metformin is a big question mark. And the TZDs, it's kind of a plus, my double-edged sword, reducing MACE, but maybe aggravating heart failure complications. The FDA, for a number of reasons, some being drugs that almost came to market, that in late stages of clinical development were found to have adverse effects on major adverse cardiovascular events. The FDA, beginning in 2008, mandated that any new type 2 diabetes therapeutic coming to the US market would have to demonstrate cardiovascular safety. They had already given up on cardiovascular efficacy because nothing everything had failed before, but they just wanted to be sure that we weren't going to increase cardiovascular events. And that led to this cottage industry of dozens of clinical trials as new therapeutics were coming to market. And we have extensive information on these 3 drug classes that were emerging in the early 2000s, the DPP-4s, the GLP-1s, and the SGLT2s. I won't bore you with the DPP-4 inhibitor trials. They were huge, they were expensive, and the event rates between placebo and DPP-4 inhibition were absolutely superimposable. There's no benefit, there's no risk, so they were safe, but there was no advantage to using a DPP-4 inhibitor versus other medications. These are studies targeting glycemic equipoise. So the hemoglobin A1C in both groups were very similar, trying to see to tease out if there's a specific benefit of being on one medication. Then the SGLT2 inhibitors were next to release their data, and here things got really, really interesting. So remember, you're filtering glucose at the glomerulus, and if you measure the glucose in the proximal tubule, it's identical to what's in the plasma. And that wouldn't be a very efficient use of calories, would it, if you peed out your glucose? It would be very inefficient. So there are these transporters, SGLT2 predominantly, and also SGLT1, that resorbs 100% of glucose entering the proximal tubule so that we don't urinate out any glucose in most circumstances, unless you are exceeding the threshold, which is 180 milligrams per deciliter, and that's the safety valve that I was alluding to before. Now, if you come in with an SGLT2 inhibitor and block this transporter, you open up the floodgates and you release glucose. And you can lose about 70 to 80 grams per day or about 300 calories per day. If the glucose is in the urine, it's not in the plasma. So this is the healthy nephron, excretes glucose at 180. As mentioned, the diabetic nephron excretes glucose at 240 for unclear reasons. And when you inhibit SGLT2, you bring it all the way down to 70. So you can have a normal glucose. If you just take one of these medications and you don't have diabetes, dip your urine, you'll be 4+ glucose. You won't develop hypoglycemia because the body has compensatory mechanisms to prevent that. So the first trial that came out was the EMPA-REG outcome trial. And this was a landmark because in 2015, we reported that for the first time, there was a reduction in MACE from using an anti-diabetic medication. And the driver of the MACE benefit was the third component, which is CV death. And here you had a 38% reduction in CV death. A very early diversion of the event curves that was really striking, not before seen in any cardiovascular trial.
Silvio, would you be able to explain what MACE is?
I'm sorry, MACE, major adverse cardiovascular events. So that's the trio of non-fatal MI, non-fatal stroke, and CV death. It's been a classic outcome in lipid trials, blood pressure trials. CV death was down 38%. And this is a secondary outcome, was heart failure hospitalization that was reduced by 35%. At that time, when we saw these data, we were puzzled because we were doing the trial for safety, just to be sure that the drug wasn't increasing cardiovascular events, and we were shocked to see these huge benefits. So other trials with SGLT2 inhibitors, there are five of them in this meta-analysis, showed similar benefits. The overall outcome is a 10% relative risk reduction for MACE, a 15% relative risk reduction for CV death, and a more robust 32% relative risk reduction for heart failure hospitalizations. And these data were so exciting that the cardiologists, particularly heart failure cardiologists, began to put together heart failure dedicated studies that included non-diabetic patients. So these were individuals with either HFpEF in some studies, HFrEF in other studies, a mix in some studies, and they were all positive. And there was no interaction between those patients that had versus did not have diabetes. So the treatment effect, the hazard ratio was identical between those who had type 2 diabetes and those did not. So very quickly, within 3 years, these drugs have now become standard therapies in heart failure. The cardiologists, not just heart failure cardiologists, but general cardiologists are beginning to prescribe them very frequently in their patients with cardiovascular disease. This was also a secondary outcome, but we stumbled upon this strange benefit on progression of chronic kidney disease from these compounds. And here the data suggested a nearly 40% risk reduction in the progression of CKD defined by development of macroalbuminuria, doubling of serum creatinine. It changes from study to study, but other SGLT2 inhibitor trials showed the same thing, or most did, and the average hazard ratio was 0.62, so a 38% reduction. Nephrologists came on board and started doing CKD trials, including both diabetic and non-diabetic patients, and guess what? They found the same outcome. So nowadays, although the nephrologists are a little bit slow to change their practice for a variety of reasons, cardiologists tend to be a little quicker. They're beginning to prescribe these medications in their patients with both DKD, diabetic kidney disease, but also in patients with other glomerulopathies, et cetera. And I'll show this data because I know Clara's here, and this is a collaboration that we had using EMPA-REG outcome data that suggested that for new diagnosis of obstructive sleep apnea, there was a potentially, these are uncontrolled data, so I mean the drug was randomized, but this was not a dedicated OSA trial, but these are from case reports. There seemed to be halving of the new diagnosis of obstructive sleep apnea. Did not seem to be related to weight loss. We did a mediation analysis. It didn't seem to be related to the amount of kilograms that these patients lost, which is about 2 kilograms. We're not exactly sure why this occurs, but we're doing more studies. And we replicated this. This is with Brian Wojcik, who is in our faculty in endocrinology and also a sleep medicine physician on your faculty. This is from Vertis CV, which is an Ertugrul-Flozin study, and we found almost an identical risk reduction in sleep apnea. So stay tuned for that. The other drug class are the incretin-based therapies, right? The GLP-1 agonists, and more recently the GLP-1 GIP co-agonist. And this takes advantage of this interesting hormonal system that communicates between the gut and the pancreas, resulting in less glucagon and more insulin after you eat a meal. So these are meal-related increases in these peptides that have very prominent effects on metabolism. A reminder, DPP-4, the DPP-4 inhibitors are also diabetes medications. This enzyme chews up your own incretin hormone. So if you inhibit the enzyme, like a double negative, you increase your own levels. But these pale in comparison to the pharmacological levels that you achieve with the injectable GLP-1s. There are pervasive effects of GLP-1 on biology, most of which we don't understand, but there are GLP-1 receptors in the brain. They decrease appetite in the gut, in the pancreas, and even in the heart. So there's been lots of interest as to whether these medications, similar to the SGLT2s, would be the holy grail of diabetes treatment, that you'd control glucose, you'd lose weight, and you'd also have a beneficial effect on cardiovascular outcomes. And this is the first trial that showed that. So this is the EMPA-REG outcome trial for the GLP-1s called LEADER with a daily liraglutide, showing a 13% reduction in MACE. And since then, there have been 8 additional large GLP-1 based CV outcome trials, and the average MACE effect is 14%, a reduction in CV death of 13%, MIs by 10%, and strokes a little bit larger by 17%. All-cause death is reduced, heart failure hospitalizations as well, although not as large as we see with the SGLT2s. And there are some renal benefits, but certainly not as prominent as we see with the SGLT2s. And this is the GLP-1 GIP coagonist tirzepatide that showed, when compared to the best-in-class GLP-1 drug, which at that time was semaglutide, there was a significant larger reduction in hemoglobin A1C, with many patients getting down below 6%, which we've never seen before in diabetes clinical trials. And these huge effects on body weight. So these are 12 kilogram losses in a diabetic population, so translating to more than 25 pounds from this. Now, the names get very confusing out there, and the drug industry has made it more confusing because they have different names for these compounds, whether they're marketed for diabetes or for obesity. So even though I'm not supposed to go through names in CME, I'm trying to be balanced and present all the names, but this is what your patients know about. So I think it's important to understand what these names mean. So these are the type 2 diabetes drugs that are GLP-1 or GLP-1 GIP based, and these are the obesity drugs. These are the same compounds. So Ozempic, that you all have heard about, is semaglutide injectable. Rybelsus is semaglutide oral, only marketed for diabetes. Wegovy is the same compound. The doses are a little bit different, but not substantially, trust me, and it's marketed for obesity. Tirzepatide is Mounjaro, and that is only available in injectables, and the obesity dosing is called Zepbound. And then there's a bunch of others that you probably will never hear about or prescribe, but these are the ones that are garnering lots of attention in the lay press because, as mentioned, everybody and their uncle are taking these medications, including the Kardashians. Okay, so in terms of the guidelines, these have obviously been altered dramatically by what we just learned about since 2015. So the GLP-1 agonists have a beneficial cardiovascular effect, SGLT2s, both MACE and heart failure, and kidney. So as you might imagine, these drugs are now favored when we're trying to reduce those complications of diabetes. So this is the latest iteration of the ADA guidelines. And the bottom line is that the decision to treat a patient with diabetes has to take into account a very simple question: is, does your patient have CVD, any form of CVD, heart failure, or CKD? So if it's cardiovascular disease, you start with either a GLP-1 or an SGLT2, no longer metformin. If you have heart failure, it's clearly an SGLT2. And if you have CKD, it's clearly an SGLT2, as long as the GFR is over 20, because at a certain point, the drug doesn't work if there is no glomerular filtration. And then after you've made that decision, then you look for other drugs to adjust for glucose control. Completely different from what we talked about in 2015, where we were focused on glucose control alone. So it's comorbidity-based treatment, not dissimilar to the statin, using statins in patients with CVD, irrespective of their LDL. It's GLP-1, SGLT2, and then using other drugs like metformin, SUs, TZDs for their glycemic efficacy and for their weight loss efficacy. I actually don't like these guidelines. I think they're way too confusing. There are too many arrows, and they're thoughtful and they're correct, but I'm not sure they're all that practical. And I'll show you my tweak of the guidelines, which is much simpler. This is the latest, which is the ASA coming out saying that if your patient is on a weekly GLP-1, which everybody is on, you have to hold it for at least a week before having surgery or a procedure involving general anesthesia, because they're concerned about, there have been anecdotal reports of gastric contents during intubation. And now the guidelines don't make sense because these medications, they are weekly, but they actually last about 3 weeks. So you still have gastric contents in your, but you'll hear about this from our surgical colleagues and our anesthesia colleagues, and it might affect things that you do in the MICU as well. So I actually think, and we've been writing guidelines for a number of years, I think the guidelines are way too complex and need to be simplified. And this is where we're heading in diabetes. And some of this will need to wait until these are generically available. The Flozins, the SGLT2s will become generic in 2026. Not sure about the GLP-1s because they're biologics and they're harder to get generics on the market. But I think that, and particularly when the drug industry is now developing small molecule GLP-1 receptor agonists, the peptide-based GLP-1 agonists have to be injectables. Or with the oral semaglutide, it's a very elaborate oral system that cannot be combined with other medications. So once we get small molecule GLP-1 agonists, and there's one in phase 3 clinical trials, then you can think about combining them with SGLT2 inhibitors, which is where we need to go. So I think that all patients should be on SGLT2 and a GLP-1 from the get-go. I don't care if they have CKD, because if they don't have it, they will have it. I don't care if they have CVD, because if they don't have it, they will have it. So this makes more sense once the price point is at a point where these are affordable medications. Right now, they're not. They're like $400 to $500 per month for an SGLT2 and $1,200 to $1,300 per month for a GLP-1. It's not conceivable that all patients can be put on that. But once the price point is down, irrespective of price, let's just talk about the science, all patients should be on this. And then you should add metformin if you need more glucose control. And then low-dose pioglitazone if you need more glucose control, especially if you've had stroke or fatty liver, where these drugs have been particularly effective. And then if you need it, and I think very few patients will actually require this, then you can use an SU or basal insulin. It'd be very, very simple, kind of a recipe, and it would probably control 95% of our patients with diabetes. This is the Yale study that I alluded to before. It's called IRIS. Walter Kernan was the PI, helped out with Larry Young and Kathy Foscoli. And here we showed that pioglitazone in a non-diabetic population of patients, these were just insulin-resistant patients with normal glucose or maybe pre-diabetes, had a 24% risk reduction in their future stroke and MI rates if they had a prior stroke. So this was a stroke study, and this has colored my attitude toward pioglitazone, particularly low doses where you can mitigate some of the side effects. So in terms of the take-home messages for the pulmonologist, and I'll wrap up and hopefully leave 5 minutes for some questions. Patients with diabetes that you see in your clinics and that you admit to your ICU are now on a wide spectrum of glucose-lowering medications, often in complex combinations, and now frequently including the GLP-1 agonists and the SGLT2 inhibitors. You'll also see heart failure in CKD patients who are on these diabetes drugs, but they don't have diabetes. And I know that gets confusing, but they're evidence-based now. These are so-called pillars of therapy for both HFrEF and HFpEF. Actually, the first drug class that has a class 1 indication in HFpEF. It was a wasteland of clinical trials previously for a variety of reasons, and also the CKD. The GLP-1s have revolutionized the treatment of type 2 diabetes due to their huge effects on BMI. And this benefit also extends even to a larger degree. Non-diabetic individuals lose more weight when they're using these GLP-1s, and their cardiovascular benefits have been proven, including the non-diabetics. A select study was announced last month showing that in CVD patients with obesity, those that were randomized to semaglutide actually had reduced cardiovascular events. So there's evidence basis both in diabetic and non-diabetic patients. And both the SGLT2s, I didn't show you the GLP-1 data, but there's also data with GLP-1s may prevent OSA. Whether they improve Prevalent OSA, I think is an interesting question, but for another day. And inhaled insulin has been out for like 10 years. Nobody uses it, but you should know about it because it uses your organ to get absorbed. Like other non-insulin agents, SGLT2s and GLP-1s are typically stopped on admission. We can discuss whether that's a good thing or a bad thing, but that's the current recommendations, particularly in critical illness. Heart failure patients should probably continue their SGLT2 inhibitors unless there's some adverse effect from them. Remember that SGLT2s are associated with euglycemic DKA, particularly if used off-label, and I'm not recommending that, in type 1 diabetes, where they actually work in terms of better glucose control and weight loss, but the safety issues are paramount in those circumstances. So you just need to be aware in anybody who presents with a metabolic acidosis who are taking these medications, even if their glucose levels are not that high, because they could have euglycemic DKA. We talked about the new ASA guidelines about holding the GLP-1s at least a week before surgery. And finally, we didn't address this fully, but I mentioned them. You'll see a lot of patients on these continuous glucose monitors. The Yale New Haven policy is to allow them to continue to use it, but we still check finger sticks for kind of medical legal reasons, although they're supposed to share any concerns they have with the nursing staff if they see ominous trends in their glucose going up or down. And I think with that, I will stop and take this.
Thank you so much for that amazingly informative talk. We'll open up for questions. I already see a couple hands up. I'll first give the mic to Clark.
Silvio, that was great. Thank you. I'm actually not going to ask you about the sleep apnea data, other than to say that we have a newly funded R01, both of us, with Ian Nealon as a mechanistic clinical trial to see if this can be a treatment. I noticed I had two quick questions. I noticed that in your revision of the 2022 guidelines that you proposed, that you were suggesting GLP-1 and SGLT2I together. And it was my understanding that they have additive cardiovascular benefits. So that's question number one. And so that makes sense maybe when they come off patent. The second question is, I'm curious about all of the guidelines I think that you mentioned were really focused on diabetics. And are there any guidelines for pre-diabetes? Or are we saying this is obesity? So there aren't any. So those are the two questions.
So the first one, let me start with the first one. So I believe they're additive, but we don't know for sure. To do that, it would be a 2x2 factorial design, SGLT2, GLP-1, both, and neither. The equipoise now is the main concern with doing these trials, right? You can't take cardiovascular patients and randomize them to placebo now that we know that these drugs, so it becomes tricky. The best data is from Amplitude, which is a F-paglenitide study. It's a Korean GLP-1 that's not marketed in the US. But they had about 600 patients. So it was the most recent clinical trial of GLP-1s. And there was lots of use of SGLT2s in that study. I think it was 600, maybe even 700 patients had SGLT2s in addition to their GLP-1. They came in on it or were treated by their doctors with it. And when they did a statistical inquiry as to whether the treatment effect of the GLP-1 was as good or attenuated in those patients with baseline SGLT2 inhibitor use, the answer was no, it wasn't. In other words, patients on these medications garnered as much benefit from the GLP-1s as those not taking the SGLT2s. It's an indirect way of answering the question, but it's not like being on the SGLT2s decreases the benefits of the GLP-1. So most feel that that the drugs are additive. We're doing the SOUL study now, which is oral semaglutide study. We have like 30% of our patients are already on an SGLT2. So we'll have really robust data. But again, it's not randomized. The SGLT2 inhibitor use is not randomized. The GLP-1 use is. But we'll be able to ask the same questions. But the real question is whether they could be synergistic, because the feeling is that the GLP-1s are more anti-atherosclerotic. They lower blood pressure, they lower obesity, they improve lipids, they decrease CRP, we think they probably reduce the atherosclerotic process. We don't think that's what's going on with the SGLT2s. We think it's hemodynamic, that your afterload and preload reducing from this mild diuretic effect. There may be an anti-adrenergic effect of these medications. There's not a lot of good evidence that it's truly anti-atherosclerotic. So wow, that's a pretty powerful combination. You reduce athero with the GLP-1, and you improve hemodynamics with the SGLT2, but there's no data to support that notion. The second question, simple answer, no. There's no authoritative guidelines for prediabetes. According to ADA, if you have prediabetes, it's lifestyle change. Consider metformin if you are not achieving your glycemic targets with lifestyle change. We've shown with SGLT2, so we've done analyses on pre-diabetic patients from some of our heart failure studies, and we've shown that the SGLT2s are as powerful as metformin, about a 32% risk reduction in pre-diabetes. So they do protect against the development of diabetes, but there's no guideline-driven approach to using these medications in that circumstance. Oh yeah, I mean, if you have an obese patient, you put them on semaglutide, and they don't get diabetes, it's an indirect benefit. You're doing it for the weight, and they don't get diabetes. We'll take that. That's good too.
There's one question from Richard online. What about the more than $1 trillion cost of Ozempic and other similar agents will decrease in healthcare costs related to cardiovascular disease and other things ultimately offset this, you think?
So I'm not sure I totally understand the question, but I think they're alluding to, what is the net benefit to society? I mean, $1,300 a month for 64% of the population being obese is crazy. We did a back of the envelope calculation once. If you put every diabetic patient on a GLP-1 and SGLT2, that cost would be more than the total cost for every other pharmaceutical that's used for all other disease states. So you couldn't obviously do that. Now, whether there's a downstream effect on reducing MIs and stroke, sure, but I'm not sure. Those are really complicated health outcomes studies that are difficult to wrap your hands around. So you need a long-term investment and a robust data set to show that the upfront costs are being offset by the downstream reductions in MIs, strokes, et cetera.
Thank you. There's one last question from Sandy here in the audience.
Thanks for an awesome talk. I feel like I learned a lot. That was fantastic. I think a lot about implementation of guidelines, and it sounds like you've sat on a number of guideline committees. And I think what I struggle about with the 2024 update is that, I don't know that this is really implementable. Like you said, this is like thousands of dollars. Insurance is not going to cover this, especially for our most vulnerable patients. So I was wondering if you could speak to that at all, thinking about diabetes management in folks who are underserved, that we can't implement these guidelines.
Yeah, when you write guidelines, if the question is whether you stick to the science and what should be done, or whether you incorporate the cost effectiveness, which is it's a really good question. But to be cost effective in diabetes, we have good glucose lowering medications. Metformin is pennies a pill. Sulfonylurea, even pioglitazone, is extremely cost effective. So you can definitely get good glucose control. The problem is that none of these medications have actually demonstrated, or maybe pioglitazone has, based on IRIS, but none of these medications have had these huge reductions in ultimate cardiovascular events. So I don't know how to answer your question, but often the latest and greatest, I'm sure this is the same in pulmonary medicine, the latest and greatest end up being the most expensive. So do you incorporate, as a writing committee, do you incorporate the cost effectiveness? That's really hard to do because those studies often are 10 years out from the clinical outcome studies.
Thank you very, very much. That was an amazing talk.